Hello, good afternoon. My name is Mark Bonten. I'm a clinical microbiologist and epidemiologist at the University Medical Center in Utrecht. And I'll welcome you all to the first WE4YOU webinar meeting of the REMAP-CAP family. So now official part of a new family, the REMAP-CAP family. So on the screen, you can see the program that we have for today. This will be the first meeting of a series. I will give a very brief introduction, and then the leader of the REMAP-CAP Europe, Lennie Derde, will take over, followed by Lorraine Parker with questions and answers, and then I will close again. It's a very short introduction. REMAP-CAP is something that started 6 years ago, and it started in preparation of a future pandemic that we at that time and in the years to come could not imagine. So we had no idea how an epidemic or a pandemic would look like. We were part of a European funded project, PREPARE, which stands for Preparing for a Pandemic. And our task was to set up a research infrastructure starting in ICU to be prepared for a pandemic. So we guessed that if there would be a new pandemic, most likely it would be a respiratory tract infection, probably caused by a virus, and a significant amount of patients would need support in ICU. So therefore the ICU was chosen as the setting to set up the study. And in order to set up the study, we choose community-acquired pneumonia as the disease to study. So the REMAP-CAP infrastructure, the platform, was actually built in the ICU since 2014. And it was made to be prepared for a pandemic. So whenever something would hit us as a pandemic, that we could start immediately by adapting the platform to address the questions that were needed at the time of the pandemic. And that makes it so fascinating to see that after all these years of preparation, I'm not saying that I'm very happy that we had the pandemic, but since we had no choice in that, at least not a reasonable choice, we need to deal with that pandemic, and then I'm happy that we have REMAP-CAP. So after a few years in preparation, Lennie Derde took over my role in the preparing the REMAP-CAP infrastructure. She serves as the International Steering Committee member from Europe, and she's actually leading the dance of REMAP-CAP in Europe. As you know, REMAP-CAP is also executed in Australia, New Zealand, United States, Canada, but now we're addressing here from Europe with Lennie Derde. So I will give the floor to Lennie Derde to talk about the humble beginnings of REMAP-CAP, which is should not be very humble. We have now more than 900 patients with COVID enrolled, and I think 8 or 9 domains opened, but that will all be explained by Lennie Derde. I really hope you enjoy the webinar, enjoy to get information about REMAP-CAP. There's ample opportunity at the end to address questions, and we certainly hope that you will be enthusiastic to work with us in rolling out REMAP-CAP in Europe to include more patients. And even if the pandemic ends, the infrastructure will be maintained for addressing relevant questions in the ICU population and beyond that. So with that, Lennie Derde, I'll give the floor to you.
Thank you very much, Mark. And what I want to do today is I want to kind of show you the photo album of the REMAP-CAP family. So we're all behind a Zoom screen now. We can't really see each other, but we are working together and we're all part of the same research family. So hopefully in the future, we can meet in person. And today I'm going to take you on a little journey of how REMAP-CAP was conceived and how it grew up to be the trial that it is today. So as Mark said, the trial was conceived in 2014. And this was actually related to the previous pandemic, which is the Mexican flu pandemic. That was in 2009. And here you can see kind of the pandemic wave for that. And in that pandemic, even though people commenced early in writing protocols and trying to start clinical trials, by the time they had submitted these protocols to the IRBs and got approval, the pandemic was essentially over. So in 2009, in the Mexican flu pandemic, essentially no intervention research got done in the ICU. And a couple of intensivists got together because they were a bit frustrated about that. And they decided that they were going to write up a wish list of how they would do things if ever a pandemic was to hit again. And this is the summary of that wish list. So what they said is, if we're ever going to do pandemic research, it needs to be pre-planned. You need to think in advance about the design and the execution of the trial. Preferably, most of the trial is already approved by IRBs. That would save a lot of time and energy. And most ideally would be if you could already have a trial actually up and running, so practiced, including patients with a disease that looks very much like what you would expect in a pandemic. And as Mark has explained, for a respiratory pandemic, and that's the pandemic that would affect ICUs, the disease that looks most like that in peacetime, as we call it, is CAP. So this is something that they started with. They wanted to do a randomized controlled trial, but randomized controlled trials, classic trials, have two huge problems if you want to do them in a pandemic. So first of all, they are robust, but they're not very flexible. So you have to pre-specify everything. And the other thing is, you're not really learning while the trial is running. So what happens in a traditional RCT is you start including patients, you pretend not to learn anything, and then usually like 5 years later, on the day you close your database, your knowledge magically appears, and then you are quite confident that intervention A is better than B. But that's obviously not how it works. And wouldn't it be great if you could look under the hood during the trial? Because during the trial, information accrues, and that's not really used in classic RCTs. There's not a lot of opportunity for that. So the second problem of RCTs related to researching a pandemic is they are a one-trick pony. They can do only one thing. They compare A to B, control versus intervention, and that's it. But that's not how we treat patients. So if a patient comes in with pneumonia into your ICU, they don't get one treatment. If a COVID-19 patient comes into your hospital, they don't get one treatment. They get antibiotics maybe because we may think there's a bacterial infection. They may or may not receive antivirals. And if they receive antivirals, it could be A, B, or C. They may receive immune modulators. They receive a certain anticoagulation strategy. So patients receive a whole regimen of treatments, not just one treatment. And if you don't randomize all these aspects, how are you going to know the true effect of that intervention for that patient? So essentially, what they realized is they were trying to do 2014 communication with a 1948 phone, because 1948 is the year the first modern day RCT was conducted. It was streptomycin versus nothing in patients with pneumonia. And this group realized that this phone desperately needed an upgrade. So they said, you know, on top of our wish list, what we really need is a type of trial that uses modern day technology, that can do multiple things at the same time, and that can be guided by the data that accrue in the trial, that can be flexible and adaptive. And they found out that adaptive platform trials may facilitate doing research in a pandemic. So they got working on that. Adaptive platform trials are the modern day versions of RCTs. And when they decided they were going to do an adaptive platform trial, also in a Bayesian statistics model, they started pulling together the bricks to build that platform. And that's how REMAP-CAP started to grow up. And in the end, they ended up with REMAP-CAP. So REMAP is an abbreviation of the 5 key design elements of this trial. It's a randomized trial, meaning just like classic RCTs, it uses randomization to infer causal inference. It's as much embedded in clinical practice as it can be. It's pragmatic, and it uses very little time on the work floor, because in a pandemic, you don't really have time to do very complicated eligibility questionnaires. It's multifactorial, meaning it can investigate multiple things at the same time. It's adaptive because we learn during the conducting of the trial. And as was said before, it's a platform, and we set it up for CAP in peacetime, hoping that we could adapt if there was ever going to be a pandemic. And that's how we started building our REMAP-CAP family. And that was not always easy. because it took quite a lot of time to pull all these people across the globe together. Not because we knew that if we wanted to do research in a pandemic, we really had to have global coverage, because a pandemic doesn't respect countries or regions' boundaries. And we did face a couple of hurdles while growing up as REMAP-CAP, and we didn't always manage them as smoothly as this kid does. We faced hurdles of bringing the trials group together. We faced the fact that we had to find out how to best construct our governance and our working structures. It was also quite difficult to make IRBs understand what we were doing, or competent authorities. And we've had to explain how the trial works to many of them. That's not a problem, but it's just quite new. And you know, that's a hurdle we have to take time and time again. Even something like clinicaltrials.gov is not really suited to put in a multifactorial trial like this with multiple amendments that runs across the globe. So as Mark said, we were funded in 2014. The first patient was included because of all these hurdles only in 2018. And at that point, we had established 4 regions where we were going to do REMAP-CAP across the globe. We acquired funding in 4 different regions. And as said before, in Europe, that was the PREPARE consortium that we were funded by the European Commission. And the trial is led from the UMC Utrecht. And then in May 2019, we had an annual meeting of this PREPARE consortium. It was in Bologna. We could still travel then. And the reason I'm telling you that is I want to show you 2 slides that I showed at that meeting. Because at that time, I showed this slide. And this slide meant to tell the people listening that we had takeoff. You know, REMAP-CAP had finally had liftoff. And liftoff at that moment meant that we had 10 recruiting sites across Europe. And together they had screened 77 patients. So for us, that was a big milestone, because it was the first time that there were more patients in the trial than that there were people working to get the trial off the ground. This was really an important moment for us. And this was May 2019, so it's not that long ago. And this was my last slide. And with that last slide, I said something like, but we have to see if instead of a plane, we can become a rocket next year. The message of that is be careful what you wish for, because then came the pandemic. And we grew very fast after we were aware of the pandemic starting. We were something like a teenager that had to grow up pretty fast and take up a lot of responsibilities pretty fast in the last 16 months or so. So to just give you an idea of the things we've done since the start of the pandemic, and I think for us, the work started in January of this year, when the pandemic was still not really a pandemic, but in China, but we were expecting it to become bigger. And as Mark said, what we did is we added a lot of COVID-19 specific domains. We doubled the number of domains that are active and up and running in the last 8 months. That doesn't only mean that you have to select the most promising options, you also have to write all the protocols, you have to build the CRF, and because of the logic in especially the eligibility CRF that we have in REMAP-CAP, that takes a lot of script writing, testing, and test running. We had to write grants because we needed the work that we were doing and the expansion that we were having to be funded. We needed to submit all these new domains and all the changes in patient information folders and stuff like that to IRBs across the globe. And in the meantime, we still had to recruit new sites, and we had to go through the startup process with a lot of sites. We added a region to REMAP-CAP. So we are now working in 5 regions across the globe. The US has come on board, so that's really fantastic. And we've expanded the menu of options that we have for sites majorly. So where before the pandemic, we had 4 domains, investigating antibiotics and macrolides, antivirals for influenza and corticosteroids, we added in the pandemic a COVID-19 specific antiviral domain, an immune modulation domain, an immune globulin domain, an anticoagulation domain, and a vitamin C domain. The antiplatelets and statin domains are also ready. The ventilation strategy is on the verge of being ready. And a little bit further down the pipeline are a domain investing in ACE inhibitors, and another immune modulation domain is coming. So as a site, this may sound as a lot, but again, remember, this is a menu and you absolutely don't have to participate in everything. Even more, if you are just starting as a site in REMAP-CAP, it's better to start with a limited number of domains so you can get the hang of the trial and then add new domains as you think the questions are important and dependent on what's possible in your hospital. So the last thing we achieved in the last 8 months is our first publication. Our first publication of results that we have obtained within REMAP-CAP with you. We have obtained these results with our whole REMAP-CAP family. As you may know, we were already investigating the effect of corticosteroids in all people with CAP, but we also included COVID-19 patients in that. And what we found was very much in line with the recovery trial. We found that our strategy of giving hydrocortisone, and then we had a fixed dose arm for 7 days, and we had a shock dependent arm, that was beneficial in patients with COVID-19. And that was also found in the 2 other trials that were published also on the 2nd of September in JAMA, and in the meta-analysis of those trials and a couple of other ones published in the same issue of JAMA on that same day. So that was another big milestone in the last couple of months for us. So over the last 8 months, the REMAP-CAP family has really grown. I think Mark referred to it in his introduction. We've now included over 1,500 patients. We have over 900 patients with COVID-19 in the trial, and we have a staggering 258 sites recruiting for REMAP-CAP across the globe. In Europe, we are recruiting patients in 20 countries, which is a huge challenge, and the REMAP-CAP family team in Utrecht is working day and night to make that possible. And in those 20 countries, we include the UK, where they have a staggering 140 sites contributing to the trial. There are 78 sites active or in startup in the rest of Europe, and we are expecting to be able to recruit about 120 before the end of the year. So this REMAP-CAP family has really exploded, and I'm really happy that you guys are all a part of that. So I especially want to thank you for being part of our research family, for being involved, for including patients. I would like to ask you to contact us with any questions you may have. Follow us on Twitter and Instagram, and I hope I can answer any questions now that you may have. Back to you, Lorraine.
Thank you, Lennie. So herewith we open the question and answers. I have a first question for Farah. Farah, as a UK trial manager, and as Lennie just explained, 140 sites opening in the UK, can you provide us with your perspective on this incredible ramp up that you experienced in the UK for the REMAP-CAP study?
Hello, yes. So we have 140 sites open in the UK, and the numbers are increasing because I'm still setting up a few more sites. It has been, as Lennie says, it has been hard. It's been a lot of work. And we went from pre-pandemic having 12 sites to the 140 that we have now. And it really has been down to this collaboration between you as a sponsor, our coordinating center in the UK, and all the sites. And I think why it's been such a success in the UK, I mean, as Lennie said, when it came to all the vast menu of domains and interventions, we were able to, and it's a lot of work with the CRF, with all the documentation, with the domain-specific appendices. Pretty much as quickly as you guys could write up the documents, I was getting them approved. And the RAC and the HRA and the MHRA were brilliant with streamlining all the processes. their flexible working hours. We were able to have chats at like 2 in the morning to get stuff sorted, to get things sorted out. And so that the streamlining of processes, which we took into account for our own at the coordinating center, simplifying the documents that we needed to collect, ensuring we could do training via Zoom, making sure that we were available to make sure everyone was happy with the whole process, that everyone got you know, the appropriate training set up, and just having buy-in from the sites, from the research teams, the pharmacies, the clinical teams. A lot of you I see have dialed in today, so thank you very much. It's just been everyone working together to move forward with what is a really interesting, really important trial, and also getting the drugs available, the drugs that are really interesting, that people want to look at and use, available to sites. So that's what it's been. Hard work, but fun. Very exciting for everyone, I think.
Thank you, Farah. And could you perhaps share some perspective from your sites on how they experienced the choice in domains and the fact that they didn't, you know, have to join in on all domains and could...
So it was different. So we had a few sites that were already open pre-pandemic. And so those, there was less of the terror of opening up REMAP to all the new pandemic domains. But what we did, as Lennie said, for all of our sites, that we had to fast track site setup, streamline processes. What we said was we will start the pandemic domain, the simple pandemic domain. For example, the steroid domain, where drugs were already available at site, and then slowly add in immune modulation or therapeutic anticoagulation as they had capacity, as they felt secure in the initial domains, and depending on what drugs they had at site and what clinical equipoise was at site. I again want to remind sites, you know, that final slide where Lennie showed the ever expanding menu. I don't want our UK sites to panic that I'm going to be sending them amendments for another 5 domains. So it is going to be a staggered release of domains that are available. And it was this staggered release, I think, that really helped. So sites could take on what they felt they were able to, both physically and emotionally, what they had the capacity to. And that's why I think calmed everything down, made everything quite successful. And just being able to answer queries when sites had them, I think.
Thank you. Thank you for answering that. There's another question on the acceptance of co-enrollment with other studies as a site is doing the tactic and recovery trial. Lennie, could you speak to that?
Yeah, definitely. And it's an important question because we're investigating so many therapies that people are wondering, you know, if other things can coexist. And the answer is a definite yes. So obviously, we evaluate every trial that wants to co-enroll with REMAP-CAP, just as they evaluate us being acceptable as a co-enroller for them. But we can definitely exist next to other trials. Even more, if you, for instance, are already participating in a trial investigating immune modulatory therapies, then you can participate in REMAP-CAP, and then we would advise you not to join the immune modulation domain. But then there are still loads of other domains you could participate to in REMAP-CAP, so that you can help answer multiple questions, even if not all of them are within REMAP-CAP. So that's definitely possible.
Thank you for that response, and thank you for the question that led to the answer. There's another question here. What are your thoughts on adding a monoclonal antibody therapy for ICU patients, like Recovery is going to add for the ward patients? Who can...
Yeah, so it may be good to explain that our immune globulin domain, so that currently includes the comparison between no treatment and convalescent plasma. So obviously, dependent on how that's going and how the external evidence on convalescent plasma develops, we're going to see whether or not it sounds promising to add monoclonal antibodies for COVID-19. I think if there is going to be a signal and we don't know, then that's definitely something that can be built into that domain. I think that's where such a treatment would belong. So it's a little bit early now, but if convalescent plasma that has antibodies in it sounds promising, then we could see whether antibodies are also a good therapy for COVID-19. Yes, definitely.
Thank you. So there's an additional question, perhaps for Lennie as well. Sorry to keep you talking. Could you tell us perhaps a little bit about the differences that you've observed between the trial pre-pandemic and now that we're in the middle of the pandemic? Some differences that you would have observed.
So I think Mark can also speak to that, but I think everything is just at lightning speed. And I also think that people are really now starting to see the value of global collaboration. So even as REMAP-CAP, we're not going to solve all the pandemic problems on our own. We really need to kind of look over the borders of our own profession. That's also why we sought to collaborate with immunologists and ID specialists very early in the pandemic. Because only if we kind of merge our expertise can we find new treatments that help patients who have COVID-19, because in the end, that's our goal. And I think Mark also has something to say about the difference between us pre-pandemic and in the pandemic.
Sure. In the pre-pandemic phase, it was very difficult for us to create a sense of urgency to be part of a protocol which looks from the outside very complicated for the, let's say, very unlikely event of a pandemic. And that is something that we struggled with for the last 2 to 3 years. And then the pandemic was there. And now we've seen that many colleagues from us are really willing to collaborate in this, let's say, fascinating platform design, which can give us a lot of answers, but which will never provide all answers. So therefore, also in Europe, we set up collaborations with other, let's say, platform trials and platform trial initiatives, such as the follow-up of the discovery study, which will be named EU Response, and has also received funding from the same commission as that we get our funding from, to really align and to benefit from each other, and to have the patients benefiting from 2 adaptive platform trials that deliver answers for this disease. So a lot of has changed indeed.
Thank you for that answer, Mark.
Lorraine, can I add a little something on that?
Of course.
Just because I know there's been so much restructuring, like clinically and academically, since this pandemic hit. I also wanted to add that from a management point of view, the way that everyone was able to streamline processes during this pandemic to make things so much easier, I really hope we've learned to take these things forward, like in peacetime, to be able to make things so much simpler to run really important studies and to co-enroll and collaborate really easily, because that I think has been a massive benefit of during this period.
Yeah, I fully agree with you, Farah, and I think, and it's difficult in this webinar situation, but it would mean a lot to us if we could get input on that from different countries, because as I said before, we are working in a region, but most regions have 1 or 2 countries, and we are working in 20 different countries with 20 different systems. And streamlining processes is that would be a present to us. That's a big thing for us if we can make those things smoother. So the team in Utrecht and Lorraine, together with Ilse, who's not in the call, and Wilma are the senior project managers on that, and Clementina that you are seeing as a panelist is one of the big team of project managers that's making that work. And they're doing an incredible job. But as you say, Farah, they would love their job to be a little bit easier if we could keep some of the streamlining that was allowed to us during the pandemic. There's still a lot to learn there. And to be honest, there's still a lot of hurdles there. But we'll keep our cool and we'll just press on, and we'll manage to tackle those hurdles as well.
Thank you, Lennie. The floor is still open for anyone that has any questions. If not, I'd like to point out that in case of any further questions following this webinar and any input that you'd like to provide as just discussed, or any suggestions for a topic for future webinars, we're always open to good ideas and suggestions. I'll put in the chat where you can mail this to. And then I think perhaps herewith I will close the question and answer session and hand it back to you, Mark, for some closing remarks.
Yes, I'm unmuted so you can hear me. I sincerely hope that you all enjoyed this brief information about the REMAP-CAP study. As I mentioned at the beginning, we intend to do this regularly now, and we'll also hope to get questions and feedback from you to help us roll out REMAP-CAP further in Europe. As I mentioned already, we have received funding from the EU Commission to activate more sites. So it should be really, let's say, attractive also for sites to participate. So if you are aware of colleagues in your neighborhood that would be interested, just let us know and we will reach out to them. I think with that, we won't take much of your precious time. You're probably as busy as we are, and hope to see you all and hear from you in future events related to REMAP-CAP. Welcome to the family. And I think with that, I give it back to you, Lorraine, to close it.
Thank you, Mark. So we hope to see you yourselves or anyone that you would like to invite to join this webinar. The next one is in 2 weeks' time, again on the Wednesday at 4 o'clock. So that would be on the 30th of September. So we will forward the invitations to you again. And I see just a question coming in.
Oh.
Sorry, can we just address one further question before we close?
Sure, sure. Go ahead.
One came in. Regarding the tocilizumab arm, it is stated that in 12 to 24 hours after the initial dose, you could give another 8 milligram per kilogram dose. However, in a past study in COVID, patient plasma levels were still high enough at day 4. Question mark.
Yes, Lorraine. So let me try and respond to that. So tocilizumab is obviously something that has a long half-life. So that's why it's usually enough to give 1 dose. In some studies, like in our study, it is an option to give an extra dose. That's mainly if patients don't respond clinically. So obviously we don't know everything about the PK/PD. It would be very interesting to do a sub-study. We don't have that up and running currently. There's a lot of movement, a lot of things going on in the investigations of tocilizumab. We all know that end of July there was a report from the Covector study that they did not meet their primary endpoint. So that was not too positive. But we still think it's sensible to investigate this, and this strategy, as I said, is a strategy that's followed in multiple studies. So it's not dependent on a plasma level that we measure, but mainly on the clinical response of patients. So maybe, yeah, so maybe Lorraine, with that, because we've been closing the session for a couple of times now. But I'm going to close the session now, not take any more of everyone's time. And I think I hope to see everyone again on the 30th of September.
Thank you all.
Do we have an after party or? You're muted.
Sorry, thank you. Clementina, are you closing the webinar for participants or?
Attempting to. No.
Okay.
Not an option. Still have 15 participants in.
Okay, then we'll close. Thanks all. Talk to you soon.
Bye.
Bye-bye.
Bye-bye.